Well, welcome. I'm Greg Stone from the Mount Sinai Medical Healthcare System in New York City. Welcome to our webcast today entitled Using CT Angiography to Categorize and Stratify Risk in Patients with Subclinical to Unstable Coronary Artery Disease. And we have a really terrific panel, and that includes Ron Blankstein from the Brigham and Women's Hospital, Renu Virmani from CV Path Institute in Gaithersburg, Maryland, Joseph Schupf from the Medical University of South Carolina in Charleston, and Tony Das from the Baylor Heart Hospital in Plano, Texas. And we're really, for the next hour, going to be talking about all things vulnerable plaque, starting with our basic understanding of what it is, to invasive diagnostics, and then spend the majority of the session talking about what we know about CTA, plaque characterization, as a first research and then clinical tool. So let me start off. I'm going to give the introductory lecture on vulnerable plaque and ischemic phenotypes. So I'm going to share my screen here. So these are my disclosures. So for many, many years, we've been trying to improve the outcomes of patients with coronary artery disease through PCI and coronary artery bypass graft surgery. And for the most part, we do not reduce death and myocardial infarction by treating stable coronary artery disease. The most recent study we have is the ischemia trial in 5,179 randomized stable coronary patients who are randomized to an invasive versus conservative strategy. And overall, we really don't make much of an impact on cardiovascular death or myocardial infarction. And the real reason is that we're treating the wrong types of lesions. Okay, most of patients with stable coronary artery disease and symptomatic coronary stenosis have this kind of lesion, what I like to refer to as garden variety atherosclerosis or pathologic intimal thickening. Sometimes it's more fibrotic or fibrocalcific, but this can lead to substantial narrowing of the lumen with hemodynamic significance. It can be ischemia related, so it can cause exercise-induced angina or anginal equivalents such as dyspnea, and treating it with either PCI or bypass surgery will reduce symptoms and improve quality of life, but this type of lesion tends to be stable for decades, and it rarely progresses, it rarely thromboses, and it rarely causes cardiac death or myocardial infarction. In contrast, we want to be treating so-called vulnerable plaque, and a clinical diagnosis of vulnerable plaque are those lesions that place patients at risk for future major cardiovascular events. So I got interested in this way back when from really the NHLBI dynamic registry, and they pointed out patients with so-called stable coronary artery disease undergoing PCI, and about 6% of about 3,700 patients within a year had rapid lesion progression of these very mild looking atherosclerotic stenoses, often presenting with acute coronary syndromes. And so again, from a clinical point of view, this is what we could call a vulnerable plaque. Now, we've learned actually from the work of Renu Virmani in particular, who we're really thrilled to have on this webcast, and other pathologists, that for most patients, the cause of sudden cardiac death and myocardial infarction is the thrombosis of an underlying thin-capped fibroatheroma. And this is a TICFA, which has a large, well-organized necrotic core, which consists of cholesterol, cholesterol esters, dead lymphocytes and macrophages and other debris. And it's separated from the lumen, which is often preserved, with a very thin fibrous cap, which is metabolically active. It's often infiltrated by macrophages and lymphocytes. And it's thin, typically less than 65 microns. And when you have release of matrix metalloproteinases or other hemodynamic forces, and other causes, that fibrous cap can rupture. And the necrotic core releases tissue factor and other prothrombotic contents, and you can get sudden thrombotic transformation of the plaque, which can convert a 40% cross-sectional area stenosis into either an occlusive or subocclusive situation. And depending on the patient's own fibrinolytic system and the balance between how severe the thrombus is, versus that system, will determine whether the patient basically prevents with sudden death or a large transmural infarct or a non-STEMI or atypical chest pain, or actually is even asymptomatic, and then the thrombus can organize, and then you can have a step-stair progression in the severity of the plaque. So we often describe vulnerable plaque as the typical volcano waiting to rupture. I love this cross-sectional sagittal image of a coronary artery. You can see the cholesterol and cholesterol esters in this large necrotic core, which is just trying to burst forth from this very thin fibrous cap on the tip of the volcano. And again, we would hold our vulnerable plaque meetings, usually on islands with dormant volcanoes, because this is what they look like from the outside, but you never know what's going on beneath the surface and when they're going to actually rupture. Now, unfortunately, it's not quite this easy. Plaque rupture with thrombosis is probably only 60 to 80% of all causes of acute coronary syndromes and myocardial infarction. In a very important subset of probably 20 to 30%, plaque erosions without frank rupture cause thrombotic occlusions, and rarely calcific nodules. Now, from an invasive point of view, which is my own specialty and interest, we've learned that there are 4 FDA-approved diagnostic approaches in the cath lab that we can identify plaques that have vulnerable characteristics, either from imaging or from chemography. And I'm not going to go over these in detail, but basically grayscale IVUS, radio frequency IVUS, also known as virtual histology, optical coherence tomography, and NIRS infrared spectroscopy all have their characteristic signals that can identify some components of vulnerable plaque, whether it is the large necrotic core, the thin fibrous cap, a large lipid deposit, etc. And in the first prospect study, we took patients with acute coronary syndromes, about 700 of them, and after treating all evident culprit lesions, the ones causing the acute coronary syndrome and other hemodynamically significant lesions, we followed patients for 3 years. And we found that about half of follow-up events were occurring from those treated lesions having problems, that is restenosis and stent thrombosis, but about half of the new MACE events were arising from very mild, angiographically mild plaques that for the most part had sudden rapid lesion progression over a 3-year period. And when we looked at the individual independent predictors of those specific lesion characteristics that were likely to lead to future MACE events, we identified 3 characteristics: a large plaque burden, greater than or equal to 70%, a thin cap fibroatheroma as defined by virtual histology, and minimal luminal area of less than or equal to 4 millimeters squared. And very importantly, large plaque burden was the most important predictor. And everyone had previously thought these lesions were mild, but they're mild angiographically, but the angiogram is just a terrible discriminator of what is going on inside the coronary artery because of Glagovian remodeling and other limitations of a 2D angiogram. And when you actually look at this, it's not until you get to about 70% plaque burden where you start getting a significant incidence of major adverse events. So plaques have to have substantial plaque burden if they are going to cause an event within a 3 or 4 year time horizon. And in fact, we had thousands and thousands of plaques, too many to even count, that had less than 40% plaque burden, and not a single one of them caused an event within a 3.4 year period. And the mean baseline QCA diameter stenosis of these plaques was 32.4%. So you have many severe plaques, but you can't see them by the angiogram. But it's not enough to just have a lot of plaque burden. You've got to have the right kind of plaque burden. And again, if you look at the right, if you had what I called that garden variety plaque burden, pathologic intimal thickening, fibrotic or fibrocalcific plaque, that didn't place that large plaque at any increased risk compared to small plaque. It wasn't until you had a well-formed fibroatheroma, and especially a VH fibroatheroma, which is less than, with virtual histology, less than about 150 microns is the axial limit of detection, that your risk really started to increase. Now, we recently completed and published the Prospect 2 study, where it's now been another decade. We used near-infrared spectroscopy and grayscale IVUS instead of radiofrequency IVUS. And we did this in 900 patients who presented with myocardial infarctions, but in an otherwise pretty healthy Scandinavian population. And when we followed these patients for 4 years, now with good contemporary drug-eluting stents, very few patients are having events related to restenosis or stent thrombosis. In fact, the most common cause of future unanticipated events is new mild angiographically appearing lesions, which in this study had to be FFR or IFR negative. So here, for example, is a right coronary artery, which was subtotally occluded. A stent was implanted distally, and you can see there's mild diffuse disease in the mid and proximal right coronary artery. By near-infrared spectroscopy, most of this is a non-lipidic vessel, except for very proximally at the site of the arrow, where there's a large lipid core, which is about approximately 69% lipid over a 4 mm segment. And when you look at the intravascular ultrasound, you find that this is a high plaque burden lesion, 80.1%, despite the fact that it looks like about a 15 or 20% angiographic stenosis. And what happened here was 3 years later, the patient developed a non-ST segment elevation myocardial infarction due to rapid progression right at the site of the high lipid burden. So in this trial, we found that by far the two most important predictors of future lesion-related events right at the site of the lesion characteristics were a high lipid core burden content, a max LCBI 4 mm of greater than about 325, meaning about 32% lipid, and a plaque burden, again, greater than or equal to 70%. And in this trial, the minimal luminal area of less than or equal to 4 mm squared was no longer statistically significant. So, can we identify vulnerable plaque? The answer is yes, clearly we can. Using grayscale IVUS, radiofrequency IVUS, and NIRS, we can identify plaques that place patients at risk for future adverse cardiovascular events due to rupture, thrombosis, and rapid lesion progression. Now, I wanted to talk very quickly about ischemic phenotypes, because I've always been very interested. Some of the FFR studies, such as FAME1 and FAME2, suggested that in ischemic lesions with an abnormal FFR, there's an increased rate of cardiac death and myocardial infarction. And I never quite understood that. Why would 5 seconds or 10 seconds of ischemia be associated with cardiac death and myocardial infarction? And that's actually been held true in large 30 to 50,000 patient databases with echo studies and PET and thallium studies. So it actually turns out that the likely reason is that the more severe the lesion is, the more likely it is to cause a hemodynamic limitation, the more likely it is to have high-risk plaque features. So this is a study from Lee in 772 vessels evaluated by both CTA and FFR, showing that when you looked at multiple different high-risk plaque characteristics, the lower the FFR, the higher the number of high-risk plaque features, including positive remodeling, low attenuation plaque, napkin ring signs, spotty calcification, and the other factors that you're going to hear about in subsequent talks. And in fact, if you looked at those lesions that had 3 or more high-risk plaque characteristics versus less than 3, you had about a 4-fold higher rate of long-term vessel-related events. So it's time that if we're going to think about vulnerable plaque and we're going to try to think about how we can reduce cardiac death and myocardial infarction rates, we have to start seeing beyond the angiogram. There's a right coronary artery that's got mild diffuse disease, but why is that arrow the specific area? Is it a stable atherosclerotic plaque, which is inactive and not inflamed, or is it a vulnerable atherosclerotic plaque? And we have a variety of invasive diagnostic tools that can differentiate that plaque from other more stable plaques, perhaps placing the patient, what we sure places the patient at increased risk from events occurring from that lesion. And we're now doing studies to determine what we should actually do when we see these lesions. Thank you very much. Okay, so I'm going to stop sharing and let's have a little discussion. So I've got to really start with Renew because, we're really so grateful and we owe so much to Renew and her pathology colleagues, but I'm going to embarrass her and say really particularly Renew for teaching us so much about vulnerable plaque, and it's had a major effect on my understanding and my research directions. So Renew, let me ask you a provocative question. What's perhaps the most important thing about vulnerable plaque that we don't think about that you'd like people to understand?
I mean, you've done the right thing, because most of the stuff that we've learned has been through invasive imaging of the future events that are likely to occur, and we've identified that vulnerable plaques are important. Now, what's the most important part of the vulnerable plaque? I think you rightly emphasized plaque burden is. I think the next thing, non-invasively, it would be nice if we could tell the fibrous cap is thin, and it is, and that's something that is missing as yet. Maybe there will be means of identifying this in the future. I don't know, but I think we are all in the right direction. We are doing really well. I think we need to now enforce that people who are at high risk should start getting CT imaging being done as a routine, those who are high risk, so that we can identify these patients and they won't have their myocardial loss, as happens to a large number of them. We are at the moment doing most of our studies related to once they present. So right. I want them not to be at the time of presentation, but before that.
So when we think, Renew, with an invasive diagnostic, OCT is our only technique that can really identify, has sufficient resolution to really identify a very thin fibrous cap. It's got a 10 or 20 micron resolution. And there is data suggesting that OCT also is diagnostically predictive. I didn't have time to go into that. So let me ask you though, what is the right cutoff, do you think, for a thin fibrous cap that we should be worried about in the intact human? Okay, when we always see those 65 microns, that's after it's kind of ruptured. And even in Prospect 1, less than 150 microns was more prognostic than greater than 150 microns. So there may be a continuum, but when should we get nervous about a thin fibrous cap?
I think certainly you'll get nervous when it's less than 65, but remember, we measured it all after fixing those arteries and dehydrating. So there's a 25% loss of thickness of that plaque that has occurred because of our dehydration and fixation. So I think getting to 100 is a good number just to be safe, that we allow. And the OCT data seems to suggest that we should be in the 80s and above. And I think that is correct. I think we should start getting nervous once we have 100 micron or so.
Let me ask the rest of my colleagues on the panel. An obvious limitation of invasive diagnostics is that patients have to be on the table. So they have to have presented already with manifest, in most cases, coronary artery disease. And then yes, we can do 3-vessel imaging, which is somewhat cumbersome. And while it is prognostic, it's not widely used yet, and it's still mostly a research tool. But are there any ways that you're using these diagnostic modalities in your practices for either prognosis or occasionally for treatment today? Maybe Ron, everybody's on mute, so I'd ask everybody to go off mute. So Ron or Tony or Joe, are you using any of these diagnostic modalities? And then we're going to transition to talk about CTA. Ron?
I think when you're referring to diagnostic modalities, your question, if I understand it correctly, is the invasive modalities. And I think in my own practice, really, we identify risk non-invasively in treating. The good news is that we have a lot of medical therapy. So by the time we're sending someone to the cath lab, we've identified them to be high risk or to be highly symptomatic or to have a high burden of ischemia. Now, certainly if we are then unsure what's happening once the patient is already in the cath lab, at that point, I do think OCT and FFR and IVUS, we certainly use all those tools, but hopefully we can make those diagnoses further upstream.
Exactly. Tony, what about you in the cath lab?
Yeah, I mean, obviously in the cath lab, we have the opportunity to use all the same tools that others have, IFR, FFR. But if you take it a little bit further upstream, I'm really enthusiastic about the digital health space here, because I think that as you start looking at ways in which to risk stratify patients, one study we're embarking on right now is looking at nuclear stress testing versus high sensitivity heart rate variability with wearables. And so what we've determined is that there's been publications that say that if you can identify patients with low heart rate variability, that their risk is actually much more predictive from if they end up having an angiogram than a nuclear stress test. In the form of sensitivity and specificity for nuclear in the 25–30% range and heart rate variability in the 65–70% range. So automatically you start thinking about ways that are non-invasive that might trigger your need to take a look at patients that are in higher risk. And then as you add more data into larger data sets, some of the AI-based predictive analysis, I think, will help change that. So I'm pretty bullish on the fact that I think digital health is going to be the way to personalize the way that we look at not just a plaque, but a whole series of plaques, take the other pieces into consideration, and we'll know a lot more before we get to the cath lab or the operating suite than we know right now.
All right, so I think we all want to move upstream. We all believe that if we're going to have a major impact on the hundreds of thousands of people that are the unknown, walking around with coronary disease and then either have sudden cardiac death or present with a myocardial infarction as their first manifestation of CAD, that we're going to have to get better at preemptive diagnosis and treatment. And so that's going to require non-invasive techniques. So let's now transition. There's a lot of different non-invasive techniques, but at least from an imaging point of view, CTA is clearly the most advanced and is a widespread modality. And so let's start looking at the role of CTA in identifying some of these high-risk patients. So Ron Blankstein is going to talk to us about current usage and limitations of coronary CTA for detection of and prognostication of coronary disease. Ron?
Thank you. So if I were to describe to you what are the current uses of CTA, I wish I could turn to our guidelines. We do have a chest pain guideline, but that's not out yet. That's coming later this year. So I will start by first referring to the European guidelines. And if we look at the European guidelines in 2019, we saw the release of the chronic coronary syndrome guideline, which in the US we would just call stable chest pain, where CT now received a class 1 indication as the initial test to diagnose coronary disease. And importantly, this is in symptomatic patients. Everything I'm going to talk about is symptomatic patients. We also have calcium score, which is a test that we do in asymptomatic individuals to identify at-risk patients. And then a year later in 2020, we saw another, in fact, 2 more class 1 indications for patients who have acute chest pain or those that have low to intermediate risk NSTEMI ACS. So this is also a fairly new indication for coronary CTA. And here's an example, at least in the acute coronary syndrome space. This is a 38-year-old male who came to our emergency room about a year ago, was chest pain, had a negative EKG. And importantly, a high sensitivity troponin, which was somewhat borderline. This is mildly elevated, but clinically, the team thought this was a case of perimyocarditis because he had his discomfort seemed to change, was positioned. So they were about to discharge this patient home, but wanted to do a coronary CTA. And I think what was found here and was not anticipated is a thrombotic occlusion of the proximal RCA. Initially, we thought this was a dissection, but ultimately this was not. This was just contrast from the thrombotic occlusion. And also this young male who was 38 also had not just this lesion, but also had evidence of both calcified and non-calcified plaque in the proximal LAD, showing that he already developed diffuse atherosclerosis. This was not an incidental finding. Well, I'm sorry, this was not a solo finding, I should say. So if we now look at what are the advantages or limitations of coronary CTA, and many of these are true both in the acute chest pain and the stable chest pain setting. One of the most important ones is that coronary CTA is highly accurate for detecting not just plaque, but stenosis. And you can see here from a meta-analysis that informed the European guidelines, CTA has the highest sensitivity to detect stenosis with a specificity which seems comparable to most other modalities. Importantly, the high sensitivity translates into a high negative predictive value. So when the CT is normal or when there's no stenosis, we can be very reassured that in fact that is accurate. But it's not just about detecting stenosis. One of the advantages of coronary CTA is really the ability to visualize the whole spectrum of coronary disease. So of course, on the extreme, we have a normal coronary CTA with no plaque or stenosis, or on the other end of the spectrum, severe stenosis. But there are many individuals that have diffuse plaque that's non-obstructive, whether it's minimal or mild stenosis. And that plaque would never be identified if they underwent any other type of stress testing. In fact, if we did a stress test, such as a nuclear stress test, it would be completely normal. And it's not that these stress tests are wrong, it's just that they are designed to detect flow-limiting disease. And this is really one of the important advantages of coronary CTA, is identifying plaque that we never would detect by any other technique, unless, of course, we did invasive imaging. And you can say, well, why is it actually important to identify plaque? And I would pose 3 reasons to you. One is the fact that most stress tests that we do in the US today are normal. So even if the patient has plaque, and sometimes a large amount of plaque, if they undergo a functional stress test or a kind of a routine stress test, the chances are that that stress test will be normal because the plaque is not flow limiting. What we have learned from the PROMISE study is that most events in patients who have stable chest pain actually occur in those that have a normal functional study. So these tests are not always very commonly normal, but the events, and this is a mathematical issue, that if most tests are normal and many of those patients have plaque, it perhaps is not surprising that the largest proportion of events are occurring in patients with a normal functional study. And then another fact that I think now is becoming clearer is that the overall plaque burden predicts risks. And sometimes, for example, in this Danish study that just came out in JACC, the amount of plaque predicts risk actually better than whether the patient has stenosis or not. In other words, once we know how much plaque an individual has, whether or not they have stenosis seems to not add a whole lot for risk assessment. But perhaps the most important reason why it's important to identify plaque is that when we identify plaque in patients based on the amount of plaque, we can improve events or improve outcomes. And on this slide here, you can see various CT studies showing that the use of coronary CTA is associated with better outcomes. And I will not go through these individual studies for the sake of time, but I will share with you that the underlying mechanism, which are thought to be responsible to the improved event rate, is the identification of plaque and the implementation of preventive therapies. We certainly don't really know this in a lot of these studies, but that at this point is the prevailing thought of why plaque identification and why the use of CT is associated with better outcomes. There are, of course, limitations of coronary CTA as well. And one of them is that the functional significance of various lesions that we see on CT is unknown. So a decade ago, we saw that when patients have more than 50% stenosis, the positive predictive value in the blue bars here for identifying ischemia was only around 50%, so as good as a coin toss. But this is not unique for CT. We see this on invasive angiography as well. And this is a sub-study from the FAME looking at this, showing that patients with 50 to 70% stenosis, 65% of the time they are normal by invasive FFR. And even those that have 71 to 90% stenosis, 20% of those individuals may have an invasive FFR that we call normal because it's greater than 0.8. So what is the problem with seeing an anatomical lesion and not knowing if it's causing ischemia or being uncertain about how much stenosis it even causes? The problem was that, and this is something that we saw early on in the CTA studies and more so in the PROMISE study in the US, is that it may lead to what we would term excess downstream invasive testing. And importantly, some of these studies also occurred. These were designed to be as to simulate the real world as efficacy studies. So guidance was not provided to clinicians. They were just given the CT results. And what was observed in the PROMISE study is that there was a significant increase in invasive testing and also in coronary revascularization. And perhaps some of that is that we did not provide enough guidance to treating clinicians on how to act on those results. Now, importantly, on the left side of this slide, you're seeing results from the Scott-Hart study. So this took place in, in Europe, of course. And in this study, patients that were not just randomized to CT versus standard of care, but CT on top of standard of care, which most often was exercise treadmill testing. And in the Scott-Hart, particularly over a 5-year time period, there was no excess invasive angiography. And this is an important result showing us that perhaps if we use CT appropriately, it does not need to lead to excess testing. So the next topic I want to speak about is what actually matters the most for risk assessment. A lot of what we're going to talk about today is risk assessment. And I already hopefully showed you that the amount of plaque matters, and certainly stenosis still matters. But on CT, one of the techniques that could be used when we read CT on everyday practice is to identify these high-risk plaque findings, positive remodeling, a napkin ring sign, a low attenuation plaque, which often means a high proportion of either a necrotic or a lipid-rich plaque, and spotty calcifications. Perhaps this one is the weakest of all. But one of the important things that I want to share with you with respect to these high-risk plaque characteristics, that the overall they have a low positive predictive value. So these are very common, and when we see them, we know that those patients have a higher risk, but the positive predictive value generally is low for these. And in fact, in some studies, such as in the Scott-Hart study, once we accounted for the overall amount of plaque by calculating a calcium score, high-risk plaque characteristics did not seem to add much more for risk assessment. What are other techniques out there for looking at risk? Well, one of them is pericoronary fat attenuation, which is a measure of potentially of inflammation in the coronary arteries by assessing for increased inflammation or increased water content in the pericoronary fat. Certainly hemodynamic significance, which we can now assess with CT, is also important. Shear stress may be important as well, that plaques that have low shear stress may progress more rapidly. So there's certainly a lot of emerging techniques of what else we can add to coronary CTA to evaluate risk. But importantly, I always remind people that we should never look at CT in a vacuum. We really have to integrate the CT findings with other risk factors. For example, if the patient has diabetes, certainly their plaque is much more likely to progress. And ultimately combining this with data such as polygenic risk scores. So if we combine all of this together, and not necessarily all the techniques that you see on this slide, but all the information that we typically have on a coronary CTA, we can come up with a pyramid of risk, and this is from the recent SCCT atherosclerosis guidelines, where we can integrate not just whether patients have plaque, but the amount of plaque, the type of plaque, the extent of plaque, and the extent of stenosis. And ultimately, we can use this to come up with this pyramid to identify who are truly the patients who have the highest risk. And the reason why that is important is because we can then intensify their therapies. Now, what does that mean? So maybe a decade ago, we used to say, well, that just means a low dose versus a high dose statin. But today, as you can see on the right side of this slide, we know that patients who truly are at the highest risk, there's a whole lot more that we can offer to them beyond just statins. Blood pressure control, antiplatelet therapy, antithrombotic therapy, multiple novel agents that can now further lower LDL cholesterol, agents like icosapent ethyl. We have therapies now in the pipeline to lower lipoprotein A. So certainly there's a lot more therapies, and as these therapies that traditionally have been tested in secondary prevention high-risk populations become more available, it's very important for CT to identify who are the highest risk patients because they are the ones who may benefit from some of those therapies. So I'll pause there, and I'm sure we'll talk about this a little bit more in the discussion.
Great. Well, that was terrific. I'll tell you what, let's, rather than have a discussion right now, let's go on to Renu's talk. And Renu is going to talk about non-invasive plaque characterization from CTA. And then let's put together everything you said with her pathologic insights into an integrated discussion. So Renu?
So I'm going to speak on non-invasive plaque characterization from CTA. But obviously, I'm being a pathologist, I'm going to talk on pathology. So I think Greg very nicely presented this work. Basically, the cause of coronary thrombosis are varied, but by far the most common plaque rupture occurs in 65 to 70% of cases of sudden coronary death, erosion about 30 to 35%, and calcified is less than 5% of sudden coronary death individuals. Now, we have divided the non-progressive and progressive coronary plaques. I call non-atherosclerotic lesions like intimal thickening, which occurs in all of us, intimal xanthoma, which is nothing else but fatty streaks, which can regress. But really, lesions that can progress are pathologic intimal thickening with macrophages or without macrophages, fibroatheroma, with early fibroatheroma in which you see the macrophage within the necrotic core, and then you see late fibroatheroma with a real necrotic core, which is quite extensive. And then thin cap fibroatheroma, where the fibrous cap becomes very thin and is infiltrated by macrophages and T cells. Now, all of you have talked about comparison. Of course, the best way to assess coronary disease, I think, is going to be non-invasively to prevent future coronary events. So yes, those who present with AMI should have these invasively rather than non-invasive, which are not as good. As you can see, the resolution is not as good as compared to OCT, IVUS, or by far the best what we're doing in our lab in autopsy cases is micro CT, where we can identify really in terms of 3 to 5 micron resolution. So we need to study what are the precursor lesions of plaque rupture, which we've all known as a vulnerable plaque, a lesion that can go on and cause a luminal thrombosis. But what we identified as an important way of saying these are lesions that are likely to go on rupture are necrotic core. The larger the necrotic core, the more likely, and especially late necrotic cores, they are the ones who are going to go and rupture. Thin cap fibroatheroma, that is the fibrous cap is less than 65, cap infiltration macrophage T cells, and cap composition is type 1 collagen, which are very similar to those of rupture, except here there is a discontinuous, that is the plaque has ruptured, that is the cap has ruptured. So if we can identify these, I think we would be able to do so. Now, this comes from Udo Hoffman's lab many years ago. As you can see in 2010, he did a comparison looking at the hearts that he got at autopsy, did my CT angiography, and then did with and without angiography CT imaging to identify what were the high-risk plaques, and we did the pathology in these hearts. And as you can see, he came up with a napkin ring sign, which was a sign which would tell you that there was a necrotic core with positive remodeling, with or without calcium. Didn't matter, but usually there was spotty calcification as well. Now, this work came out of Japan, and they showed that if you could identify high-risk plaque with positive remodeling or low attenuated plaque, and look at stenosis, that is significant stenosis greater than 50%, 70%, you can see that you could tell those without those features, that is no high-risk plaque, no significant stenosis, had the cumulative event rate was extremely low or not at all. And that the highest event rate occurred in high-risk plaques with, at the same time, presence of significant stenosis, and then in between the others. So this was one way, this was one of the first studies to show this, and this was very exciting to me at least. That told me that we can eventually find patients who will not, we can prevent sudden death from occurring in patients who have never presented with any symptoms and they die suddenly. So for better risk stratification, pathologic features of high-risk plaque characteristics can be adapted for improving predictability. So calcium score correlates with plaque burden. Coronary calcium is an established risk predictor, as you've heard already, and among the stable patients in PROMISE study presenting with suspected coronary artery disease, most patients experienced clinical events had measurable coronary calcium at baseline, and fewer than half had abnormalities on functional tests. However, an abnormal functional test was more specific for cardiovascular events. I think pathologic studies suggest that calcified plaque burden and coronary calcium scores are not elevated in the substantial proportion of patients with ACS. So I think this study very nicely showed that if you look at high density calcified plaques, they are associated with lower risk of acute coronary events. So the ones that had acute coronary events were compared to control patients who did not, and they were matched for everything. And you can see diameter stenosis was less, was higher in those with acute coronary syndromes. Area stenosis was higher, cross-sectional plaque burden was higher, fibrofatty necrotic core was higher, but the 1K plaque was lower. That means 1,000 plaque Hounsfield unit, those who had that high risk, high calcium score, actually they had less acute coronary events. So it's suggesting that highest calcium scores do not occur, those with highest, the acute coronary syndrome does not occur in those individuals. So this is calcification by radiography, lesion type, and you can see they are speckled calcification. You can see in the mid portion, these are erosions, thin cap fibroatheroma. Fragmented calcium is more common in rupture, that is lesions which are greater than 3 millimeter in length, the calcium. And you can see that whereas in stable plaque, those that are stable, that is, they have healed plaque rupture or fibrocalcific plaque, they have diffuse calcification. And those lesions do not go on and cause any thrombosis usually. So here what we did was we looked at percent narrowing. We said fibroatheromas, thin cap fibroatheromas, ruptured, healed plaque rupture, and fibrocalcific plaques. What is the distribution of these luminal narrowings? And you can see that in what is most interesting is thin cap fibroatheroma. If you look at, and plaque ruptures, you look at plaque ruptures, greater than 75% narrowing occurs in large percent, 70%. They also have high necrotic core, but they don't have high calcium. If you look at thin cap fibroatheromas, same way, they have high necrotic core, whether they are 50 to 75% or greater than 75% narrowed, but they don't have that much calcium. Highest calcium is seen in fibrocalcific plaques, even if they're severely narrowed or not so severely narrowed. These do not go on and cause thrombosis. So what's the amount of calcium in each one of them? You can see the same thing showing by histology. It looks the same. Stable plaques have the most calcium, whether it's sheet calcium or nodular calcium. As shown here, you can see more than 50% of plaques will show you, or healed plaque ruptures will show you severe calcification, whereas the unstable plaques have much less calcification overall, and the type of calcium is not like sheet. Large amount of calcium, that is diffuse calcification, is not seen in these lesions. So here's adaptive intimal thickening. Can we recognize all? I think by far OCT is the best way to recognize, OFDI to recognize the arterial wall, and of course you can recognize one micro CT. And some people have said even by IVUS you can recognize, but I'm not convinced of that. Now, going on and saying, late fibroatheroma, can we recognize these lesions? These are lesions, napkin ring lesions. Yes, you can easily recognize, as you can see here, the same lesion is shown here. You can see the lipid core here. This is the lumen. And you can see that this is a napkin ring appearance, giving you the napkin ring. This happens not to have calcium. But here is one which has calcium, and it does have a necrotic core, and you can recognize by micro CT the cholesterol clefts as well. Here's fibrocalcific plaque with calcification. You can see this area of calcification, fibrocalcific, diffuse. You can see it by OFDI, you can see by CTA, and micro CT. Of course, you can recognize both the sheet calcium as well as nodular, as shown here on the right. What about late fibroatheroma with intraplaque hemorrhage? Now that is the next thing that we should start to recognize, which would also help, but we can recognize the necrotic core. And if you look at by CT, you can certainly recognize the calcium, you can recognize the necrotic core, and you can even see the fibrous cap. That's tomorrow's, I think, technology, which will come in CT. Here are lesions showing you plaque rupture, plaque erosion. Often there is little calcium in these lesions, as you can see here. This is the site of rupture. You can't see, but you can see that it is rich in lipid core. And plaque erosion is even harder because it doesn't necessarily always have a very high necrotic core, but you can have, and you can see the lumen is not severely narrowed in these cases. So what should be detected by clinical coronary CT for the identification of future site of plaque rupture and better patient risk stratification? Large necrotic core, fibrous cap, which is infiltrated by macrophages, expansile remodeling, intraplaque hemorrhage, neovascularization, adventitial perivascular inflammation, and you could add fat and fatty spotty calcification. Elucid VascuCap software analysis and histopathology validation study has just been performed, and this involved 125 patients who had undergone CT MRI before endarterectomy, carotid endarterectomy, and we measured the histologic findings blinded to the fact that what the CTA or MRI showed. So each one was blinded. And this is what they did. This is to show you that they can recognize, we looked at these plaques, we did the plaque identification saying which one was what, we were unaware what CT showed, and the CT people were unaware what we had seen. So we identified intraplaque hemorrhage, we recognized collagen, we recognized necrotic core, we recognized macrophages, calcium, and lipid pool as well. So these were identified, and eventually they were read and matched, and it was possible to show that they could read these areas. So histologically defined plaque stability phenotype can be readily determined automatically from the CTA across all epicardial vessels in one acquisition. So this is, I'd like to thank Dr. Yusato and Dr. Atsushi Sakamoto, who helped me put this together. So thank you so much for this ability to show you my work.
Well, thank you, Renu. That was terrific. So, you brought up a lot of points that I think for a lot of people have been very confusing for a long time. We know that coronary artery calcium detected by CTA predicts events, predicts atherosclerosis, but it's actually those heavily calcified lesions are the stable lesions. And people have not really understood that distinction. And one of the things that has not been done yet with CTA, not nearly as well as has been done with invasive diagnostics, is to try to look at the individual characteristics of lesions as predictors of lesion-related events, as opposed to patient-related events. So how good, and I'll ask you this and Ron, and then maybe we'll go ahead, the signs, the napkin ring calcification, napkin ring signs, spotty calcification, low attenuation, expansive remodeling, et cetera. How good are those to predict lesion-related events?
I think they're pretty good, but they're not 100%. Obviously, we have many of these in a patient who's high-risk patient. What we need to identify is what is a definite way of saying this particular plaque. If a patient has 3 such lesions, we need to be able to say, this is the one is going to go on and rupture. I think we're getting there, as you did in your work. Greater than 70% narrowing is a predictor of what's, along with high-risk plaque that is necrotic core or maybe with or without spotty calcium, then we can actually predict that this is the one which is likely to go on. I think we'd get better if the resolution was better of CTA. Maybe I'm just dreaming,
sure.
but I think it's going to get better with time.
So Ron, you made a comment and that surprised me, and you actually said that some of these plaque characteristics maybe don't add that much to just calcium detection. Do you want to expand on that?
Yeah, my comment was related to the Scott Hart study. This is a study led by Michelle Williams that where calcium score was available for everyone. And once accounting for that, the presence or absence of high-risk plaque characteristics actually did not add to risk assessment. And in general, in that study, they included a lot of different high-risk features, but the positive predictive value, which I think some of this is true for invasive studies as well, it was around 4% or so. So even though it increases risk and it can tell us which patients that are higher risk, it's not that we can look at that plaque and have a lot of certainty that that individual plaque is where the trouble is going to be. And of course, some of this is because patients today are in very good background medical therapy. We have to remember that. But I think another reason for this is that when we look at plaque features, we often on CT now, especially in some of these studies, we're using a binary classification. Is the remodeling index more than 1.1? Napkin ring sign, is it, it's present or absent? low attenuation plaque, is it present or absent? And I think there is a gradient to a lot of these features. So if someone has a remodeling index of 1.8 and we see tremendous expansive remodeling, obviously that's going to have higher specificity. But the studies today are pretty basic. They've used all of these as binary, and I think that's one of the reasons why we're seeing a positive predictive value that's, I think, worse than a lot of people would have anticipated.
Yeah, plus when you also consider the fact that one, the people that are undergoing CT tend to be relatively stable. So you're talking about 1 to 3% 1-year adverse event rate. So it's overall very low in the entire population. And number two, when you talk about the decreased resolution of CTA, I mean, what we learned from our invasive studies was that even though grayscale IVUS has a lot better resolution than CTA, grayscale IVUS wasn't enough to differentiate plaque features. We needed to go beyond. We needed to go particularly to OCT and to near infrared spectroscopy. So I think that's really the perfect introduction into what the Elucid technology is trying to do, and that is to use more advanced algorithms to be able to use CTA to give us better delineation of plaque characteristics. So let's go to Joe's talk. So Joe Sheff is going to talk about the ElucidVivo plaque analysis methodology, technology, and some case reviews. So Joe.
Hello, everybody. Thank you for tuning in. I'm Joe Shepp from the Medical University of South Carolina, and I'm very excited to be part of such a stellar faculty that has been assembled here for this webinar. It's truly an honor to be part of those very special individuals that contribute so much to our field. These are my disclosures. Everybody on this webinar probably knows that the greatest strength of coronary CT angiography is its extremely high negative predictive value to rule out coronary artery disease. And that has been reinforced with the results of the recent ischemia trial. Based on those results, obviously, now CTA has been moved front and center in the workup of patients with suspected coronary artery disease. There's more to coronary CTA. Coronary CTA enables non-invasive plaque evaluation, which can be used for diagnostic and prognostic purposes, and we've known that for a long, long time. We know that there are characteristics to a plaque pertaining to its morphology and function that can be used to predict major adverse cardiac events. These are plaque burden, composition, and many other factors and many other features that can be evaluated when you look at coronary artery plaques with CT. Now, how can we make that better? How can we really make sure that we extract all the information that is inherent in a coronary CTA dataset? I think one of the most advanced softwares that us in this quest is what is now called ElucidVivo, which was a VASC app in the past, now called ElucidVivo, which is an objective and quantitative coronary artery analysis software. It has a lot of advantages and features that help us overcoming some of the Achilles heels of coronary CTA. One of the most important features in that realm is the mitigation of calcium, which results in blooming artifacts and blurring effects, which oftentimes, especially with more inexperienced observers, makes them overcall lesions, simply because the calcium looks much bigger in a CT image than it looks in real life. So ElucidVivo does away with that. And in addition, it accounts for a huge number of biological variables and biomarkers that can be extracted from a coronary CTA dataset. Those image restoration algorithms that help us make our images better, extract most of information out of our dataset, enhance the visibility of the true lumen, and allow the analysis of atherosclerosis formation in the vessel wall. It characterizes vessel wall morphology and perivascular tissues, such as perivascular fat, for instance. It accounts for very subtle features in tissue presentation, such as the lipid-rich necrotic core that's so important in the etiology of sudden cardiac events. The patented blurring algorithm and the iterative optimization enables identification and quantification of substances of interest by representing the true underlying image, which is the prerequisite for the subsequent image analysis and extraction of biomarkers. These are the different features that are evaluated on a histologically validated level. These features are being extracted utilizing machine learning, and they're supported by objective histologic explanation of hundreds of tissues. Software is unique in that manner. This is the only non-invasive plaque assessment technology that has excellent correlation with histopathology as an objective standard of truth. The features that it gives you after extraction are those of plaque structure. We get values on remodeling, wall thickening, ulceration, stenosis, dilation, and overall plaque burden. More importantly, it very granularly looks at the composition of the plaque in terms of calcification. That aforementioned lipid-rich necrotic core is one of the most important features. Intraplaque hemorrhage, the matrix of the plaque, the fibrous cap, as we've heard, like the thin fibrous cap atheroma, that is really what kills you. So it analyzes the thickness of the cap for you, and it also looks at another emerging and very important biomarker, the perivascular adipose tissue. This is what the output based by the machine learning algorithm would look like. An example of a lipid-rich necrotic core on the top and of a mostly calcified plaque at the bottom, and here the vessel segment after segmentation and color coding of the different plaque components in figure A. Now, the color coding is such that the lipid-rich necrotic core is aptly color-coded in yellow, calcification in green, the matrix in blue, and intraplaque hemorrhage is labeled in red. And this is the output that gives you numeric values to quantify all of these, the calcification, the intraplaque hemorrhage, the lipid-rich necrotic core, the matrix, the calcification area, areas of intraplaque hemorrhage, measures for the lipid-rich necrotic core, and the minimal cap thickness of the fibrous cap covering the plaque. And I think with this abundance of information, this software really lives up to Renu Vermani's stipulations. It gives you all the values that, as she said, are important in the evaluation of plaques and maximize the information and their predictive value. It actually gives you a likelihood ratio based on phenotype classification, giving you a risk based on what the plaque looks like with histology, with histopathology validation. So this is the histopathology expert annotated for the tissue components. Here's the example of a more fibrospecific plaque, which would be considered more stable. And here, like a bad player, thin cap fibroatheroma with intraplaque hemorrhage coded here in red. And based on these features and based on the algorithm's knowledge of histopathology, it would give you a risk ratio for each of those plaques. Obviously, for the thin cap fibroatheroma, that risk would be exceedingly high, 74% in this case, that this plaque would be unstable, whereas the more fibrous calcific plaque obviously has a much lower risk of being unstable with 30%. Imagine what a powerful tool that is in risk prediction, in risk stratification, risk management, and patient outcome. We actually put that to the test. We performed a study where we used CTA data of patients where we had 2-year follow-up. And by using ElucidVivo, we were able to achieve an 87% accuracy for predicting MACE. And that is obviously way better than any of the traditional risk factors that we have. And it's way better than only visual analysis of the plaque. The characteristics that were the most important and most strongly associated with adverse outcomes were the cap thickness, the lipid-rich necrotic core volume, the lesion length, and the positive remodeling ratio. Those were the strongest predictors whether or not a patient would have an adverse event. So based on that, we believe that plaque morphology-based FFR assessment, let's do that again. Break here. I just distracted by my phone, I put it away. But as always, we want to take it a step further and kick it up a notch. The ElucidVivo plaque analysis is extremely important and valuable to tell us about the future of a patient and to identify individuals that are at risk of having a major adverse cardiac event, to risk stratify and risk management in future. But we also need to know which patient needs our help right now. So we need to find out which lesion is actually hemodynamically significant and reduces blood flow to the myocardium. So another element that that software gives you is prediction of fractional flow reserve based on CTA data. And it's unique in the way how it does it. This is not using computational fluid dynamics or anything like that. It is using the plaque morphology. It basically uses the features of the plaque to determine to what extent a vessel can still expand to see how blood flow is impacted by the presence of a plaque. And that is based on artificial intelligence and obviously outperforms the visual stenosis interpretation, as you can see here. Like with all FFRCT softwares that we've seen, we become a lot more specific in calling a plaque stenotic. So you're saving a lot more patients from going to the cath lab unnecessarily, and you can management your patients according to their FFR analysis, whether they should undergo revascularization or not. I think from what I said, the clinical potential is evident and is very congruent with everything else that has been said on this webinar. The clinical potential consists in very granular, patient-centric, tailored care by quantifying arterial plaque composition and structure. So this is precision medicine. Non-invasively informs risk through quantification of the lipid-rich necrotic core and intraplaque hemorrhage. You can utilize that to evaluate the response of different therapies and dosing. And obviously in a time where we need to show our efficacy in what we're doing with our patients, that will become more and more important. It also allows pre-procedure planning for interventional procedures such as TAVR, peripheral procedures, or coronary and carotid intervention. So this is the workflow. You have your CTA, which is then evaluated with the ElucidVivo output, which can be reviewed by whoever performs the image acquisition. And the outcome determines patient management, whether a patient is being put on optimized medical therapy, regular therapy, or if invasive diagnosis and treatment is needed. Let me show you a couple of case examples, how the software plays in terms of MACE prediction. Typical presentation of a 68-year-old man with a known coronary artery disease. He has new onset of atypical chest pain. On his coronary CT angiogram, he has extensive 3-vessel disease, but he has no high-grade stenosis. No intervention was done. At the ElucidVivo output here with all these yellow areas indicating lipid-rich necrotic core areas. So these are high-risk markers. And based on that analysis, the patient was placed at high risk based on the software's output. And indeed, the patient developed, unfortunately, myocardial infarction 7 months after the coronary CT angiogram. So a true positive for the software. Another example, 70-year-old man, known hypertension. He has a new onset of chest pain for 8 hours. On his coronary CT angiogram, he has multi-vessel disease with moderate stenosis in the LAD circumflex and right coronary artery. No intervention was performed. However, the napkin ring sign was detected by the software, which predicted an increased risk for MACE. Indeed, unfortunately, again, 4 months later, the patient had a major adverse cardiac outcome. Next example is a 51-year-old man. He has a known hypothyroidism and he smokes. He has a new onset chest pain and shortness of breath. CTA shows 50% proximal LAD stenosis. No intervention was performed. The ElucidVivo analysis did not detect any features that were suggestive of increased risk, so he was placed in the low risk category according to indeed, the patient survived fine over 2 years follow-up. So a true negative for the software. The last example, a 66-year-old woman, known hypertension, chronic chest pain, low to moderate probability of coronary artery disease. This was a follow-up CTA showing 3-vessel atherosclerosis with a moderate LAD and diagnose stenosis. No intervention was performed. The software did not detect any high-risk features, and accordingly, patient was placed into the low-risk category. And again, the patient survived over the next 2 years without any cardiac events. In conclusion, I think CTA-based plaque morphology and quantitative features increase the ability for MACE prognostication compared to the use of clinical risk factors alone. Plaque assessment tool as ElucidVivo further adds to the value of coronary CTA in CAD management and holds a very promising future role in patient management to identify patients who need our help right now and in future.
All right, well, great. Well, let's obviously a lot more to learn about this, but the potential is huge. So let's go on to Tony. Tony, I'd love to hear how you're using the Elucid technique in clinical practice right now.
So I just enjoyed being part of this webinar today. I've learned a lot from the previous speakers. And, you know, the point is that how is this going to be used as we continue to incorporate this technology into our clinical practice? And so for me, as an interventionalist who does a fair amount of vascular interventions, we've just embarked on projects looking at the predictive value in the peripheral space. So I'm going to reflect a little bit on some things that Greg and Renu and others have said, but I'm going to look a little bit into the future with our presentation. So obviously we've already learned that plaque stability and complexity can be determined by CTA. I'm not going to belabor this because the 4 previous talks basically identified the fact that we can use certain identifiable risk stratification phenotype classifications to start to determine whether patients are at risk or not. The point of this is that we want to take that information and then extrapolate it into the vascular space. We know that from the coronary space that this is a tool that's cleared to measure things that are very important to identifying risk, including lipid-rich cores, et cetera. And Greg and others have identified trials in which this was elucidated, the Prospect trial, as well as some of the others that you see here. But ultimately what you realize is that coronaries are not just small peripheral arteries. And as we learn FFR and invasive ways of correlating the coronary space, are these applicable to the vascular space? And it turns out they probably are. So if you look at coronary pre-procedure planning, as Joe and others mentioned, that 3D visualization can tell you things like lipid-rich core, necrotic centers. It may change the way that you actually do the procedure if you identify a high enough risk procedure. He showed a couple of examples where it was identified that there were, thin set fibrous caps. There were other places where there were napkin rings. You might have considered intervening on those patients and using specific technologies as mentioned here. But my point is that can we take that coronary information and then extrapolate it to other spaces? And it turns out that it probably is that you can. We're starting to do some studies with the Elucid team and looking at CTs for patients who are going to undergo carotid procedures and looking at some of the historical knowledge that we have on these images. We know that, as Greg had mentioned previously, that grayscale analysis tells you certain things, and particularly in the carotids, this has been identified particularly with high lipid inflammatory cells when you see a low grayscale median value. In addition, black areas near luminal surfaces also show more vulnerable type of plaque in the carotids. as well as discrete white areas in the histological plaque. IVUS, as we know, with virtual histology has been studied for vascular conditions. It's never really taken off as an identifiable tool that we would use to predict, but I think that as these predictive analysis start to use AI and machine learning, that those predictive analysis, particularly in spaces where the outcomes could be quite detrimental, like a carotid leading to a stroke or a lower extremity intervention leading to distal embolization, this recurrent of aggregating the data in an AI-based technology like we have here may actually turn out to be very useful for us as we do vascular interventions. So we can use them in clinical applications for pre-procedure planning. So for instance, if you have a complex looking lesion and you're intending to do a carotid stent or a TCAR or carotid endarterectomy, recognizing what the potential is for that plaque to embolize, you may consider using additional proximal and distal protection, consider using TCAR, flow reversal, or carotid endarterectomy, or be just prepared for neurorescue, things that you wouldn't necessarily need in every condition, but with certain calcification, with lipid-rich necrotic cores, and with matrix that look like they are vulnerable and may embolize, you may want to consider changing the way that you do the procedure. Is this something that we think that may be worth reviewing in patients prospectively? Joe had mentioned this, and I think it's very true that not only from the cardiac space you can see that the MACE events were increased, but in this same predictive way in studies like the CRISP consortium, where almost 200 patients were reviewed, that there was a very strong correlation where morphology predicted what the outcomes were for major adverse neurologic events. So you can start to take this ground truth histological assessment and these evaluations by CT and determine that there are patients that may do poorly if not recognized by these type of technology. And this is something you can follow over time, like we do for carotid disease now. We do carotid duplex and ultrasound, and when the patients have 50 to 70% lesions, we follow them every 6 months. If you added CT to that and you knew that calcification or the lipid-rich necrotic cores or other factors through time and evaluation with large database of patients, that you could then identify when you should intervene, because largely carotid disease is done for asymptomatic patients to prevent stroke, as opposed to coronary interventions, which are frequently done when patients have symptoms. So this is a lot more predictive and useful in our clinical practices than potentially even the cardiac space would be. In addition, if you think about extending this into the peripheral vascular space, 3D evaluation of vascular disease in the lower extremity might identify patients that have heavy calcification, where we might want to consider distal embolization protection, reducing the risk of distal embolization problems with critical limb ischemia patients. We may want to think about atherectomy and changing compliance, and it may also allow for better drug-eluting balloon penetration, as has been pointed out in other studies as well. So this type of three-dimensional view may actually be very useful in predicting both carotid and lower extremity events, many of which are unpredictable in some of the technologies that we have today. As mentioned previously, this might be the future standard for pre-evaluation for coronary disease for patients that are undergoing TAVR. So for us, I think that this personalization of taking the vessel, identifying a phenotype, using AI to make each lesion the study criteria for its own outcome, understanding what the structure is of the lesion, expression of the signals that include the problems with calcification and lipid-rich cores, and taking that with outcomes data and putting that into a system where you can then create an algorithm that tells you whether patients should have treatment done in a way that's different than what we do today. I think this might be a very useful way of looking into the future in personalizing our vascular care for these patients. You can take these clinically validated and now personalized images, and with these precision technologies, you can then determine how patients would be evaluated and treated. We're looking at doing this in our own centers and looking at patients prospectively with these type of images. And ultimately, that will allow us to tailor the care. So you take the CT scan with patients that have lower extremity disease or carotid disease, and then looking at their plaque stability, and then taking into account other portions of their evaluation, whether it's their demographics or their other social determinant risk factors, or other things that they're on medication-wise, as others mentioned, that those things may play into what we would consider to be non-supervised machine learning identification of high-risk plaques, things that we wouldn't necessarily find unless you had large databases of information. So in conclusion, I think the future of this imaging, including AI-based lesion morphology analysis coupled with outcomes, particularly in the vascular space, is going to be quite important. And we're embarking on studies to help understand that. And this precise intervention and treatment combination, looking at the images, evaluating the outcomes, choosing the equipment, and planning tools for these type of cases, I think will make a big difference. And we know that this technology with the AI-based algorithms are really the first that are cleared for histological validation, looking at these tissue characteristics. And ultimately, I can foresee a time when one day in the future, we might see the ability to predict what the outcome of a procedure is before we intervene. So we might have those two brains on the right, both Renu and Greg, in the procedure room before we actually embark on the first catheter placement. And that would be a very interesting look into the future. Thank you very much.
Well, thanks, Tony. That was a brilliant closing lecture for us, and I think it really paints a very bright future of what we have to look forward to. So I think for time, I'm just going to conclude. I think this was really a brilliant session that looks not only at today, but looks at tomorrow. We've learned that vulnerable plaque is real. You can diagnose it with invasive techniques, but that's not practical in many patients. And we all agree that we need to move upstream to be able to identify patients that are at high risk for myocardial infarction, acute coronary syndromes, and sudden cardiac death, as well as progressive peripheral vascular disease, et cetera. We certainly know that global atherosclerosis is the more vascular beds that are involved, the worse the prognosis for the patient. It's not just all coronary disease, it's hypertensive, cerebrovascular stroke, claudication, critical limb ischemia, et cetera. We've really seen that CTA is a very exciting modality. It's now widespread. It's very easy to acquire these images in a very brief amount of time. And you do get important prognostic information from a CTA, but there are limitations to CTA. And we've seen extensively now about the ElucidVivo plaque analysis software, which is one approach, the only FDA-approved approach, which is based on histologic validation of plaque characterization to be able to identify particular plaque subtypes. And it adds a lot of information in terms of necrotic core volume, intraplaque hemorrhage, and it goes beyond that in terms of the potential to assess biomechanics, genetic expression, FFR and flow limitation, et cetera. So with one simple test, you may be able to get one, an assessment of global vascular burden in the patient, two, understand plaque composition, three, understand hemodynamics, shear stress, gene expression, and much more. So it sounds like science fiction, but it's really here. It's really maybe just around the corner. Ongoing validation studies clearly have to happen in large data sets, so we know just how robust the data is. We can really understand the positive and negative predictive values of certain different combinations of plaque features. And so we know when to intervene with different levels of intensity of either pharmacologic therapies, lifestyle interventions, or perhaps even invasive interventional or surgical approaches. And underlying all of this is a real deep reliance on machine learning, artificial intelligence, and all the digital innovations that I think are changing the face of modern cardiology and medicine. So I want to thank all our speakers and the opportunity to present this webinar to you today. I hope you enjoyed it as much as I did, and we'll look forward to giving you regular updates as more data and insights emerge. Thank you very much.